So I've mentioned conservative management a couple of times. What does that mean? Well, that means medications, mainly NSAIDs, oral steroids. Those are the things we think about with treatment for disc herniation. Physical therapy is something that patients will fight you on and say, I don't want to do that. I've tried it in the past. It didn't really work for me. It really has quite good results with disc herniations and getting people kind of over the hump and getting them through their disc herniation. So, not something to shy away from. And, I try to get everybody to go through that on a more, real world practicality kind of note. A lot of insurance companies will now not allow you to get the MRI until you've done a course of physical therapy, because it does help so frequently that they realize we don't really need to put this person through an MRI until they've failed physical therapy. And then epidural steroid injections, I use these for both diagnostic and therapeutic reasons. A transforaminal epidural steroid injection will classically get at that traversing nerve root. You can also get parasagittal epidural steroid injections. And remember, we talked about there being a compressive and an inflammatory component. So what I tell patients is the steroid injection is not going to fix the compressive component. It's going to fix the inflammatory component. So if you have somebody that maybe has a not so large disc herniation, story's not making a lot of sense, and send them for a steroid injection. And if they get better, if they get a L4-5 transforaminal epidural steroid injection on the right, and they have right-sided small paracentral disc herniation, and they get better with that injection, we got a lot more data to go to surgery with now and feel more comfortable doing what you're doing. We'll talk about surgical intervention. And then what do we need to consider here? Well, conservative therapy is really the first line. You try to limp people through with conservative measures and avoid surgery if you can. I can tell you that I had a mentor in residency who had a massive disc herniation early on in my training, and he adamantly refused to get surgery. And he fought through it for weeks on weeks on weeks. He actually was admitted to the hospital at one point for pain control. And he fought through it and eventually got to the other side and was fine, had no residual symptoms. And it was very powerful because he would use that to talk to patients, basically saying, I've been in your shoes, I've been there, and, I fought through it and got to the other side. Long-term outcomes are really similar for conservative treatment and surgery. However, you get quicker relief with surgery. So we sort of expect radiculopathy to resolve within 8 weeks from onset, but surgery, the relief is relatively quick, a lot of times instant after surgery. So that's something to consider. Another thing to consider is spontaneous disc resorption. We can see that especially with sequestration. So if the disc gets completely separated from its other component, from the a piece of the nucleus gets separated from the rest of the nucleus, a lot of times it will resorb on its own, and that's obviously better for the patient, doesn't require any surgery. Cost is, of course, something to think about in any of these cases. And then what are the presenting symptoms? Is it acute? Is it progressive? What's the severity? How is it affecting somebody's quality of life? All those things are really important to consider.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.